I'll be very quick here. So I was asked just to talk about if there's any agreement at all on PAD screening. Go ahead and scroll through these quick. My conflicts aren't relevant to this at all. Just so that you all know, a third of patients above the age of 50 who smoke or have diabetes or over age 70, regardless of risk, have PAD. So go ahead. The population doesn't know anything about this disease. Go ahead. Patients with PAD are grossly undertreated compared to patients with coronary disease. And here's the data, one of many studies suggesting that the lower the ABI, the higher the cardiovascular event rates, the higher the ABI, the higher the cardiovascular event rates. And yet there is this statement out there from USPSTF that says that you shouldn't screen for PAD in any way, shape, or form, and that it may in fact invoke harm. Next. That's their task, their recommendation. These are the same experts who just, go ahead, same experts who just told the public not to screen for breast cancer. So they got great press for this recommendation. Go ahead. And obviously we all wouldn't want to take on Nancy Snyderman on the NBC News as she tells how terrible this decision was. So I think Josh Beckman and Mark Krieger and I wrote a response to the task force about their very short-sighted decisions, and this is just a graphic that Josh had put together that depending on the mortality rate that you accept from the literature, that goes anywhere from 27 to 57%. You can save anywhere from 2 to 9 lives just by doing per 100 patients by doing an ABI. Next. Now, I'm not here to represent the ICAVL, although I am the incoming president of this organization. I wanted to put this up here to remind you that the ICAVL does in fact deal with PAD screening. And so in their document, which is on the web, you can go ahead, thanks. They basically talk about all the questions that you guys asked. They talk about how the test should be done. And for screening, we do not believe multiple cuffs at multiple levels need to be done. This is just an arm and an ankle, period. Next. They do talk about what the protocol is. This is very basic, but in fact, it's what the industry standards suggest. We don't have to waste our time on this now. Next. And then the big question that you asked me is, does the person who screens for PAD have to be a registered vascular tech? Clearly, the answer is no. There aren't enough registered vascular techs to do this, to really have an impact on the population. Being an RVT means a very small percentage that need screening would actually be screened. There are plenty of alternatives, and a number of studies have looked at training physicians, house staff, nurses, secretaries. People use all sorts of groups. I would say this, I really don't believe it's just as easy as wrapping cuffs and pressing a button. I think there's more to this than that, but I do think that certainly many people other than registered vascular techs can be trained to do this and do it reliably. I think that's it.
Great. Michael, is that a societal feeling and recommendation as well, or is that?
I don't believe, and I'd be happy to have my colleagues address this, I don't believe a society's dealt with the actual issue of whether an RVT should be the only one to screen for.
Let me put again for the record, Michael is representing himself as a KWL, not ICAVL president. However, this is an issue that we brought up to the ICAVL and other society would like to discuss. You hit the nail right on the head that there are not enough RVTs, and if we are going to adopt a national screening program, we need to enable the first liners in primary care, the MDs and physician assistants and nurses to be able to do these tests. So let's move on to...
Can I just say one thing?
Yes, go ahead.
There are a lot more issues related to this than just whether or not you can do the screening. I mean, issues of like what an abnormal ABI is, whether it's the highest or the lowest, and issues related to the recently published AAA study in JAMA on, okay, so you identify a low ABI in somebody who's asymptomatic, does it really affect any outcome? So I'm just bringing these up for...
No, let's discuss it. What we'll have Michael there. So the issue, of course, comes to all of these three technologies that we're discussing here, that how does it affect the outcome? As you know, this is the core of the debate. Matt and Rita the other day, and throughout 2-3 years that we've published shape is we're the vulnerable patient, as we say, it's been a rock and a hard place. and you're asking us for a 10-year or 5-year follow-up study, whether it can change the outcome. So the great thing is today you're bringing the PAD angle to our discussions. We didn't have that in the past. Let's have you comment on that. How do you two wrote an editorial after USPTO, how do you address that issue? The outcome, whether PAD screening changes the outcome.
So, I guess what I would say is I refer them currently to the JAMA paper looking at the aggregate of 16 studies showing that it reassigns a third of women and a quarter of men beyond the Framingham risk score. And I think the recent paper in JAMA actually shows us that aspirin stinks more than anything else about PAD. Aspirin has been failing all over the place. And this is just another place where aspirin has failed. And aspirin hasn't worked in primary prevention ever, even though there are recommendations. It didn't work in the physician's health studies of primary endpoint. It didn't work in the women's health studies of primary endpoint. So, there's enough epidemiologic data going back to 92, 2004, and then the GET-ABI study in 2009, showing that asymptomatic PAD patients have a very high event rate. And so the combination of the high event rates and the reassignment of risk class suggests that it's a pretty good predictor. And I take the recent paper to mean that aspirin in the current medical environment may not add much to where we are.
Correct. Well, that's the same stand that Matt had with coronary calcium. We're going to talk about the IUT as well. Emil, do you have any comments?
Yeah, I think I agree with what Josh said about the issue of reassigning cardiovascular risk, but the issue that comes up with all the imaging modalities talked about here, and when the task force will say yes, go ahead and screen, is if when you screen, if you treat the patient, does it change outcome? Now, here we've said, Josh, I totally agree with, changes that, it's got to change outcome. But the study hasn't been done where we screen, the ABI is 0.5, those patients are then treated prospectively, and the patients who didn't get screened versus the ones that did, therefore they had a better benefit. I'm not sure I'll ever get to that, but that's what I think. Would you guys agree? That's what I think the task force wants to see, like AAA screening,
Right.
where they screen patients, they found a AAA, they intervened, and they had better benefit.
I'm not sure I'd use the task force as the arbiter of all common sense.
I didn't say it's common sense, Josh.
I had the opportunity to
It's
speak
actually
with
stupid.
their head of their chief science person. They didn't really recognize that PAD was atherosclerosis. They kept referring to it as a risk factor. And I tried to make clear that it's not equivalent to hypertension, but it was lost despite over an hour of conversation.
Let's move on to Emil's slides, and then we'll come back again to some of these discussions.
Next slide.
Go ahead.